Hello everyone. Today we'll be discussing about angiotensin receptor neprilysin inhibitors, that are ARNIs. So before going to the main topic, we should know what is renin-angiotensin system. That is, first what happens is liver produces what is called as angiotensinogen. So this angiotensinogen, whenever the liver produces it, this is metabolized into angiotensin 1 by the renin, which is released from the kidneys. Okay, this angiotensin 1 is later metabolized by an enzyme called as angiotensin converting enzyme to converted to from angiotensin 1 to angiotensin 2. And this angiotensin 2 then acts on the adrenal glands to release more aldosterone. And what does this aldosterone does is aldosterone causes increased sodium and water reabsorption. Okay, and also there is angiotensin 2 has also have another action which causes directly on blood vessels, causing vasoconstriction. So these are the main action. So what happens is this at this enzyme, where is what acts is called as AC inhibitors. The group of drugs like enalapril, ramipril acts on this enzyme and inhibits this. Whereas the angiotensin receptor blockers, that is ARBs acts on angiotensin 2 receptors so that it prevents the action of angiotensin 2. Overall, these are called as RAAS blockers. So what is the pathophysiology of heart failure is the renin overall, whatever happens in a heart failure, what it leads to, it leads to renin-angiotensin aldosterone activation. So whenever there is RAAS system activation, as we have already discussed, what does this RAAS activation means is the increased aldosterone levels. So increased aldosterone levels is to what? It causes increased angiotensin levels, causes vasoconstriction, which will lead to increase in blood pressure. Also, aldosterone causes increased sodium and water reabsorption, which will lead to more volume overload in cases of heart failure. There is vasoconstriction, which leads to hypertension. There is increased aldosterone levels, and there is increased sympathetic tone, which all eventually leads to cardiac remodeling and which is detrimental. So here we explain the mechanism again. What happens is whenever there is a heart failure, there is decreased output from the left ventricle to the chemoreceptor, that is to the aorta. So which leads to the dysfunctions of the baroreceptors, which is available, which sends and signals to the brain, which leads to increased activation of the vasomotor center, leading to increased sympathetic nervous system activity. So thus there is increased renin secretion because of increased sympathetic activity and increased activation of the RAAS system. This is what happens in case of heart failure. So this is initially is beneficial, later on it can cause to detrimental effects, and that's why we have to inhibit them in a chronic heart failure patients. Next, what comes is the natriuretic system. Natriuretic system is a compensatory mechanism which happens whenever a patient is having heart failure, with which because of there is decreased pumping from the heart. So what body has to try is it should try to excrete more water through urine. So that for that what happens is the natriuretic peptides are released from the ventricles and the atrium, which causes more diuresis and thus prevent patients from the heart failure. So thus, all patients of heart failure, because of the ventricular stretch and stress, they will have elevated BNP and NT-proBNP, which is seen in heart failure excessive patients. So again, we will discuss. This is the mechanism of formation of BNP. So initially, what is released from the ventricles is the pre-proBNP, which is later converted into proBNP. This proBNP is again metabolized to NT-proBNP, that is N-terminal proBNP, and a BNP individual. So this is important. This will be discussing it later, how it is, why it is very important in a case of ARNIs. So what are the natriuretic peptides actions? So these actions are exactly reversed to what is the actions of the RAAS system is. So again, we'll see what is RAAS system does. The RAAS system, we told you already, it causes vasoconstriction, increase in blood pressure. So aldosterone activity is high, it leads to increased sodium and water reabsorption. Opposite to that natriuretic system, what does it do is causes vasodilation, and name itself says natriuresis, that is sodium and water excretion. So natriuresis and diuresis. This vasodilation leads to lower blood pressure. Also, there is lower sympathetic tone and reduced aldosterone levels. So exactly opposite to the RAAS system. So heart failure itself is divided into what is called as two types. That is heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So what do you mean by preserved ejection fraction is that heart failure with preserved ejection fraction is when you have a ejection fraction of more than 50%. And reduced ejection fraction is one when you have this ejection fraction of less than 50%, which is again divided into mild, moderate, and severe. So mild means ejection fraction of 40 to 50, moderate is 30 to 40%, and less than 30 is called as severe. So coming to the evaluation of the management of chronic heart failure. So the first drug which was initially available for the heart failure was vasodilators, which came up with around 1980s. Later on, ARBs were included at around end of 1980s to 1990s, which was later confirmed in the 2000 again, which leads to the ARBs as one of the mainstay of the treatment in heart failure. Then beta blockers were included through these trials. Later on, mineralocortical receptor antagonists came up in around 1999 and again 2010, and the heart failure devices were there. So till around 2014, there were nowhere ARNIs were not ever included in the heart failure treatment. So all these trials till now, what is shown that addition of each drug has shown that there's a decrease in mortality as you can see by addition of each of these drugs, because all these drugs has found to have a mortality benefits. So now pathophysiology of ARNI. So pathophysiology of ARNI. So what do you mean by ARNI is again angiotensin receptor neprilysin inhibitor. So what happens is the natriuretic peptide system, which works antagonistically to the RAAS, has favorable effects on pathogens of heart failure because it causes more diuresis. That's why it has more favorable effect. So main mechanism of ARNI is that if they can increase these natriuretic peptide levels, then automatically they will be preventing patients from heart failure exacerbations. So normally in our body, this natriuretic peptides, that is pro-BNP, BNP, are metabolized by what is called as neprilysin. So neprilysin is also responsible for the breakdown of other substances, which is called bradykinin and angiotensin 2. So if you inhibit this neprilysin enzyme, what will it do? That will lead to decrease metabolism of the natriuretic peptides, and thus natriuretic peptide levels will increase, and that's why it can prevent the heart failure exacerbation due to natriuresis and diuresis. So neprilysin is also metabolizes what is called as bradykinin and angiotensin 2. So if you inhibit neprilysin, it has a positive effect of increase in natriuretic peptides, but it also has a negative effect of there will be increase in bradykinin levels and angiotensin 2, because neprilysin metabolizes this. So if you inhibit this neprilysin enzyme, there will be increase in bradykinin and angiotensin 2. So this bradykinin is what leads to what is called as dry cough and angioedema. And if there is angiotensin 2 levels that increase, it leads to more increase in aldosterone and increase in RAAS system activation. So thus, if you only inhibit neprilysin, that is not sufficient. We need to also inhibit what is called as angiotensin 2, because this angiotensin 2 increase can be detrimental. So thus a combination was made, which is called as sacubitril/valsartan. So sacubitril is a neprilysin inhibitor. Okay, it inhibits the neprilysin enzyme, whereas valsartan is the angiotensin 2 receptor blocker. So it will inhibit the angiotensin 2 here. So it works by blocking the action of neprilysin, thus preventing breakdown of natriuretic peptides. This leads to prolonged duration of the favorable effect of these peptides. Again, we see here sacubitril, neprilysin. So what does sacubitril overall causes? There is decrease in aldosterone levels, and causes diuresis, natriuresis, causes vasodilation, decreased hypertrophy, decreased fibrosis. This helps in preventing remodeling. So valsartan, as we told again, it's a angiotensin receptor blocker. So since neprilysin breaks down angiotensin 2, so if you inhibit neprilysin, there is increase in angiotensin 2 levels, and thus there can be accumulation of angiotensin 2, which can be detrimental. So you have to inhibit this angiotensin 2 also by an angiotensin 2 receptor blocker, which is valsartan. For this reason, a neprilysin inhibitor cannot be used alone, and it has always should be combined with an ARB. So bradykinin and ARNI. Another important substance broken down by neprilysin is bradykinin. So we told you again, which is already discussed, if because neprilysin metabolizes bradykinin, if you inhibit neprilysin, there will be increase in bradykinin levels, and this bradykinin can cause angioedema and dry cough. And thus, also this bradykinin is also metabolized by what is called as angiotensin converting enzyme inhibitor. Thus, So if AC inhibitors is used, bradykinin levels again increase. So that's why neprilysin is not combined with AC inhibitors, because both will cause increase in bradykinin, and which can lead to increased risk of angioedema. So thus, whenever you are switching a patient from an AC inhibitor to sacubitril valsartan, you should give a minimum of 36 hours washout period. That is once you have stopped the AC inhibitors, you should wait for at least of minimum of 36 hours before starting sacubitril valsartan, because both can have cause increased bradykinin and thus angioedema. So this is the overall mechanism. So LCZ696 is the name which is initially started before they actually named it sacubitril valsartan. So sacubitril is a neprilysin inhibitor. So this neprilysin actually metabolizes this natriuretic peptides. Sacubitril inhibits this, thus natriuretic peptides are increased and thus causing vasodilation, natriuresis, diuresis. And angiotensin 2 normally causes vasoconstriction, sodium and water retention. So if you inhibit angiotensin 2, the effects will be reversed, leading to vasodilation, natriuresis, diuresis, which is all useful in the management of heart failure. So again, we'll see this if you use sacubitril without valsartan. So what happens is, we told you again, there will be overactivation of the RAAS system. Why? Because sacubitril is a neprilysin inhibitor. And this neprilysin enzyme also, neprilysin enzyme normally causes metabolism of angiotensin 2 also. So if neprilysin is inhibited, there will increase angiotensin 2 levels, increase activation of RAAS system, and thus increase in aldosterone levels. So you should never use it without valsartan. So neprilysin inhibition alone is ineffective due to angiotensin potentiation. So neprilysin plus AC inhibition can lead to fatal angioedema due to bradykinin, and thus neprilysin inhibition plus angiotensin receptor blockade should be used. So how this ARNI actually came into picture was, they have seen that all these natriuretic peptides causes natriuresis, vasodilation, and diuresis. So it has a very much beneficial effect. So initial research, what they have done is, they have started administering exogenous natriuretic peptides. So what they thought, if you administer natriuretic peptides from outside, there will be more diuresis, more natriuresis, more vasodilation, which is all helpful in heart failure. So there are two drugs which they developed. One is carperitide and another was nesiretide, which is a ANP and a BNP analog. So both of this is actually a natriuretic peptides, so it causes natriuresis. But what they found is, it need continuous infusion rather than bolus administration, and due to the short duration of action. So that's how it can be only given in hospital setting, and in acute staging, it cannot be given for long-term management. And thus this all showed failed to show us a lot of success in a heart failure management. The alternative approach was to increase the level of endogenous natriuretic peptides. So for which the drug which came up was candozatril, which was a selective neprilysin inhibitor, which has also found a vasodilator and diuretic activity. But what they found is, there was significant hypotension which was noted with this, and thus it was also its production was also halted later on. And thus what came up in the world was, initially it was exogenous natriuretic peptides like nesiretide and carperitide. Then neprilysin inhibitors, candozatril came up. Then they tried neprilysin inhibitor plus AC inhibitors, but it causes angioedema, as we have already discussed, because of increased bradykinin. And later on, ARNI came into picture. So the main trial which brought importance to ARNI was a paradigm HF trial, which was done in 2014, which is angiotensin neprilysin inhibition versus enalapril. So what does this study do is, they took around 8,400 patients with class 2, 3, or 4 heart failure with an ejection fraction of 40% or less. That is heart failure with reduced ejection fraction. What they did is, half of the patient they made to receive sacubitril valsartan at 200 mg twice daily, and another half they made to receive enalapril. The primary outcome was a composite of death from cardiovascular causes, like what number of deaths due to cardiovascular causes or a hospitalization of heart failure. So that was the primary outcome which they kept. So what was the conclusion is that they seen that sacubitril valsartan was superior to enalapril in reducing the risk of death and of hospitalization for heart failure. So this study was a landmark study for ARNIs, and also it showed that there was a 20% reduction in cardiovascular death mortality when compared to enalapril with ARNIs. And thus ARNIs was brought into the guidelines at around 2014-15. See, we have already shown up to here. So heart failure management has also included ARNIs around this time. And now even SGLT2 inhibitors has been included as a part of heart failure management in 2019 and 2020. So this study was implied in the ESC European Society of Cardiology 2016 guidelines, which mentioned that sacubital valsartan is recommended as a replacement for an AC inhibitor to further reduce the risk of heart failure hospitalization and death in ambulatory patients with heart failure with reduced ejection fraction who remain symptomatic despite optimal treatment with an ACE, a beta blocker, and MRA. So what they have said, if any patient who is being symptomatic even on AC inhibitors or beta blockers and mineral receptor antagonist, they should change ACE to ARNI, which was a class 1 recommendation. That is, it definitely should be done. Similarly, there was a mention this ARNI to replace AC inhibitors. Even the American Heart Association also has implied the same thing. They have showed ARNI is recommended for patients with chronic heart failure with reduced ejection fraction. The next study which came up was a Pioneer Heart Failure 2019 study, which was ARNI in acute decompensated heart failure, where they took patients with heart failure with reduced ejection fraction who were hospitalized for acute decompensated heart failure. So who had acute decompensated heart failure, that patients were included, and what they did, they divided them into two groups. One of the group received sacubital valsartan 97 mg and 103, and another group received enalapril 10 mg twice daily. See, out of which this study have shown that there was 440 patients and 441 patients each. So only half of the patients were on AC inhibitors or ARBs prior, and another half they have started it de novo. Like that is, before that they were neither on AC or ARBs. So that was study. It was done, and it was shown that initiation of sacubital valsartan therapy led to a greater reduction in NT-proBNP concentrations than enalapril therapy. And also the rates of worsening renal function, hyperkalemia, symptomatic hypotension, and angioedema, that are the side effects of this, was similar in both the groups. What does ESC 2021 says that initiation of sacubital valsartan in ACE inhibitor naive, that is de novo patients, that is who have not rarely received AC inhibitors or ARBs, initiation of sacubital valsartan can be considered. So may be considered, which is a class 2B recommendation. The next trial was the Paragon HF trial 2019, which was done in a heart failure with preserved ejection fraction. So here also they have taken 4,800 patients with ejection fraction of 45% and or more, and they have divided half into sacubital valsartan and other half to receive valsartan twice daily. What they have seen is there is no significant lower rate of hospitalizations for heart failure and death from cardiovascular cause, and thus these ARNI groups are not recommended in heart failure with preserved ejection fraction. So overall, what are the indications of uses of ARNI is, first is the heart failure with reduced ejection fraction, that is EF of less than 40, which is a class 1 recommendation. Next, heart failure with mildly reduced ejection fraction, that is EF between 40 to 50%. What the new guidelines in the ESC Guidelines 2021, what they mentioned is that it may be used, that is a class 2B recommendation. In heart failure with reduced ejection fraction who are not on AC inhibitors or ARBs prior, it is also a class 2B recommendation. So how do you administer is this drug? Is that case sacubital valsartan are available in 3 formulations, 3 dosages. One is this 24, 49, and 97 of sacubital, and 26, 51, and 103 of valsartan. So overall, if you combine, it comes as 24 plus 26 is 50, 49 plus 51 is 100, and 97 plus 103 is 200. So it comes with a various brand names like Vimata, Asmata, and all. So this comes as like 50 mg, 100 mg, and 200 mg. And what is important thing is that the valsartan component in this combination has a higher bioavailability as compared to the individual valsartan. So what they said is the valsartan 26 in this is equivalent to valsartan plain 40 mg, 51 mg is equivalent to 80 mg, and 103 mg is equivalent to 160 mg. So it has to be taken twice a day and can be administered without any regards to meals. And you should allow a minimum of 36 hours washout period when if you are switching a patient from a AC inhibitor to a sacubital valsartan. And patient must be able to tolerate an AC or ARB, which they used to say before starting on sacubital valsartan. But new guidelines has mentioned that sacubital valsartan can be started without patients on AC ARBs, which is a class 2B recommendation. Dosing, what they say, if a patient was initially on a low dose AC or ARBs, who has not previously received AC ARB, you should start with a small dose, that is sacubitril 24, valsartan 26, that is 50 mg tablet total, twice per day, and every 2 weeks you should double the dose, and the maximum dose is the 200 mg twice a day, that is 97 of sacubitril and valsartan 103 twice a day. If a patient was already on a moderate to a high dose of AC or ARBs, then what you do is you can start with a sacubitril valsartan 100 mg tablet, which is a 14 mg of sacubitril and valsartan 51 mg, and every 2 weeks you double till like your patient receives total of 97 mg of sacubitril and valsartan 103 mg twice per day. So in liver and kidney disease, so what they mentioned is patient with EGFR less than 30 or who have a moderate hepatic impairment with a Child-Pugh class B, they should start with a smaller dose, that is sacubitril of 24 and valsartan 26 mg. It is not recommended in patients with a severe hepatic impairment. So renal failure is not a contraindication for usage of sacubitril valsartan. Adverse effects which was noted with this is hypotension, because we know that it causes the natriuretic peptides causes vasodilation. Also, it inhibits angiotensin 2. So angiotensin 2 is a vasoconstrictor. If you inhibit, it causes vasodilation, it will cause hypotension. It causes hyperelemia because it blocks the aldosterone action. So aldosterone, what does aldosterone cause? Aldosterone normally causes increased sodium reabsorption and excretes potassium. So if you block aldosterone, potassium excretion is inhibited, and that's why there is hyperkalemia. It can lead to angioedema, which can happen because of increase in bradykinin levels. This bradykinin can cause cough, dry cough, and since you are blocking the RAAS system, it can also lead to renal failure. What are the contraindications of ARNIs? Hypersensitivity to any component of this product, a prior history of angioedema with AC inhibitors or ARBs, or if a patient is already on renin inhibitor, that is aliskiren, or if patient is already on ARBs, that is all, because both of them can cause increase in potassium, and both of them inhibit this RAAS system. So thus it should not be used along with that. And patients who have received AC within last 36 hours, as we have already explained, they shouldn't receive this drug. Next, the most very important point is focus ARNI and BNP. See, because this sacubitril valsartan, we have said you that beta natriuretic peptides, all these beta natriuretic peptides, which is there, is metabolized by neprilysin. So very importantly, you have to note that the neprilysin do not inhibit all the natriuretic peptides. Neprilysin only inhibits the BNP. BNP and anti-pro-BNP is not metabolized by BNP. Okay, so here if you can see these are the pro-BNP, then pro-BNP, and this pro-BNP is again converted to anti-pro-BNP, and then we have is ANP, BNP, CNP. So these three are metabolized by neprilysin, whereas this is not metabolized, anti-pro-BNP is not metabolized by neprilysin. So now you think what happens if you inhibit this neprilysin? Because neprilysin metabolizes all this ANP, BNP, CNP. If you inhibit neprilysin, there will be increase in ANP, BNP, and CNP. So in patients who have heart failure, if you want to monitor their treatment, BNP levels shouldn't be used, because what happens is BNP level will be raised throughout after usage of ARNI. So it shouldn't be used for monitoring. So what should we use to monitor heart failure is you should use anti-pro-BNP. So anti-pro-BNP is not affected by neprilysin, so that's why you should only use anti-pro-BNP for monitoring. Okay. So what are the cautions you need to take, which you already take? A washout period of at least 36 hours you should allow after AC therapy if a patient have a potassium of more than 5. If a patient on any other drugs which can increase potassium, you should be a little bit cautious. Okay. Now, so how to use is that check renal function electrolyte, start with a very low dose always, and if your BP is like between 100 to 110, you start with a small dose, and who have not received previously AC or ARB, you start with a small dose, or who have a EGFR of 30 to 60, you start with a small dose. So you should double the dose every 2 weeks to the maximum dose, and recheck blood chemistry 12 weeks after initiation and 12 weeks after final dose titration. So every 3 months you should do a blood chemistry. So systemic hypertension and ARNI. So it's an also important topic whether ARNI have any role in hypertension management. So all the studies which we have available so far, what they have showed that ARNIs has been compared only with ARBs, and it had shown a beneficial effect, but it has never been compared with what is called as other hypertension drugs like beta blockers, thiazide diuretics and calcium channel blockers. So thus evidence is still lacking. Until now, it is not recommended in management of hypertension. So let's see what we have to do if some problems comes with after using ARNI. So if a patient develops asymptomatically low blood pressure, so if his BP is low but patient has no giddiness, no drowsiness and all, you need not actually lower the therapy. You can continue with the same treatment. If a patient has hypotension, that is BP of less than 100, and if he develops symptoms like dizziness, lightheadedness, so what you need to do is you shouldn't immediately stop the sacubitril valsartan. You should look for any other drug which is causing hypotension. Like if your patient if patient is on any vasodilator, okay, if there is no signs or symptom of congestion, you should consider reducing diuretic doses to minimum. Okay, if this measure do not solve, then it is depend upon a case-to-case basis, and whoever the cardiologist is treating the patient or physician treating the patient should decide upon usage of ARNIs. If a patient is developing cough, see, not all coughs are developed by AC inhibitors or ARNIs. So if a patient has a history of smoking, so that smoking itself could be a cause of cough. So first you should counsel the patient to counsel the patient to quit smoking and to monitor his PFTs or whatever is like you monitor his lung status before considering that AC or ARNIs are causing the reason for cough. So all these heart failure patients are also tend to go into pulmonary edema, which itself can cause cough. So you should try to give more diuresis. And after diuresis, also once the edema settles, then also if cough is not settling, then only you should think about ARNI and AC causing cough. And this is also you should do a trial, that is given initially you should stop, and after restarting again after a few days, if the cough is reoccurring, then it is 100% sure that it is occurring because of ARNI or AC inhibitors. Okay, so renal failure and hyperkalemia. So some rise in BUN, creatinine, and potassium is expected after an ARNI. If an increase is small and asymptomatic, no action is necessary. So what they say, increase in potassium up to less than 5.5 is acceptable, and less than 30 of eGFR is also acceptable. If declining more than 30, then you should try to reduce the dose, and also based on physician's decision, you can about to decide or change. Okay, so pregnancy and ARNIs. So till now, what is shown? ARNIs is angiotensin. This crosses the blood placental barrier, and thus it can cause renal dysfunction in the in the infant or the baby, because in the baby it can cause renal dysfunction, and thus it is contraindicated. Okay, in the fetus. So all the AC inhibitors, ARBs, ARNIs, mineral corticosteroid receptor antagonists, evaporatin, and SGLT2 inhibitors are contraindicated and should be stopped prior to conception. So this is a new trial which has came up, which was published in 2021, is the Paradise MI trial. That is patients who have acute MI within after 12 to 7, between 12 to 7 days of symptom onset, with a EF of less than 40% and or pulmonary congestion. So what they have done, they've taken this patient, and half of the patient they've given sacubitril valsartan, and half of the patient they've given ramipril immediately. So what are the outcomes they measured was the cardiovascular death, the heart failure hospitalization, and outpatient development of heart failure. Again, the total 5,600 patients, half received sacubitril valsartan and half receiving ramipril. So what they have seen is patients who are taking sacubitril valsartan has found to have decreased the cardiovascular death and first heart failure hospitalization, but this was not found to be statistically significant because the follow-up period was only for around 23 months. So what this study showed that sacubitril valsartan did not result in a significantly lower rate of cardiovascular death, heart failure, hospitalization, or outpatient heart failure requiring treatment. Okay, the safety and tolerability of sacubitril valsartan in this MI population was comparable to that of AC inhibitors. So in the latest 2021 ESC guidelines, where does ARNI stands up? Let's see that. See, in heart failure with mildly reduced ejection fraction, sacubitril valsartan may be considered, which is a class 2B recommendation. So it has been included along with the mineral receptor antagonist, beta blockers, ARB, ACs, which is the mainline treatment for heart failure. So heart failure with reduced ejection fraction less than 40%, sacubitril valsartan is a class 1 recommendation. Okay, so it is recommended as a replacement for an AC inhibitor in patient with heart failure with reduced ejection fraction. Okay, so in the last ESC guideline, what they mentioned, patient who are on AC or ARBs who are symptomatic despite on being AC inhibitors, beta blockers, or mineral receptor antagonist, then only it was recommended to start. But this trial showed that it has to be replaced because there is very much high benefits with the usage of sacubital valve stent. So here again, same. Thank you, everyone. More videos like this, do subscribe to my YouTube channel, Dr. Akif Beg. Bye bye. Take care. Stay healthy. Thank you.